Welcome everyone to today's workshop on promoting safer disinfectants in the global healthcare sector. My name is Arianna Gamba. I serve as Procurement Policy and Project Officer at Healthcare Without Harm Europe, where I oversee our project on safer disinfectants in healthcare called SAICM 2.0. Today I will be your moderator, and I would like to remind you that all participants are muted, but if you have any questions, please use the chat box and we will address them in our Q&A sessions. I also like to remind you that this session is recorded. As many of you know already, this project is financially supported by the German Agency for Environmental Protection, and today's meeting was supposed to be a physical workshop hosted at the German Ministry of Environment in Berlin. However, due to the health and safety concerns and the travel and event restrictions surrounding the current COVID-19 pandemic, we decided to still hold this event online and adapt its format to a webinar. So we decided not to cancel the event because during the pandemic, the use of disinfectants has obviously increased, both in the healthcare sector and general. So we think that this topic has become even more important in this unprecedented time. And we hope that the information and experience shared during the event today will be helpful for all of you to make purchasing decision on disinfectants. So as you can see in the agenda of today, we will start the event by discussing what are the potential hazards related to the use of disinfectants, and this presentation will be followed by a short Q&A. We will see then some best practices on the procurement and application of disinfectants from the city of Vienna and Gothenburg County. And finally, we will present the results of our project together with the case studies. And after a final Q&A session, I will also introduce you what are the next project steps and the opportunities for you to engage in the project. So please stay with us till the end of this afternoon. So I will now before we start, I will now say a few words about Healthcare Without Harm and what we do in our European office. So we are an international NGO that brings the voice of healthcare professionals to the European policy debate, but it also raises awareness and inform the healthcare sector about the importance of the environment. Our vision and mission are to mobilize healthcare leaders and professionals to achieve a sustainable and healthy world by transforming the healthcare sector to protect public health and tackle climate change. In our European office, we work on several policy areas, mainly on the impact of pharmaceutical in the environment and antimicrobial resistance, climate-smart healthcare, the importance of access to organic and plant-based nutrition while reducing food waste. And of course, as per topic of this webinar, we work also on the safe management of chemicals and sustainable procurement. So we work on all these areas closely with our diverse network of more than 140 members and strategic partners across the European region, who are mainly hospitals, healthcare facilities, regional authorities, professional associations, and environmental NGOs, to mention a few. All this is part of a global network of green and healthy hospitals that is made of more than 1,000 members representing 30,000 hospitals and health facilities. So I would strongly encourage all the participants to join this community if you haven't done it yet. Now, without further ado, I'd like to introduce our first speaker, Helena Norin. She's the Technical Supervisor of Sustainable Chemicals Management at Enviro Planning in Sweden. Helena has been working with eco-labeling for more than 25 years. She has been responsible for eco-labeling of chemical products, paper products, diapers, and textile within the Swedish Society for Nature Conservation. And this work included developing criteria as well as assessing their applications. She has been an eco-labeling expert for the European Environmental Bureau and European Consumer Protection Organization in several product groups since 2000. She regularly works with setting criteria for green public procurement, as well as the evaluation and follow-up of contract compliance. So, Elena, you should be able to see your presentation now, and you can start.
Yes, good afternoon, everyone. I'm Helena Norin, and I was introduced earlier, so I don't think I will do that. What you see on the screen is a Swedish river called Viskan. It's in the southwest of Sweden, and you can tell from this picture that this river is highly polluted. What you see here is you see spring flowers and a nice river in a nature reserve. But in fact, this is one of the most polluted rivers in Sweden. We will return to how this has something to do with disinfectants at a later stage. And I will, as I was introduced, I will focus this brief speech on the environmental part of chemicals and especially of disinfectants. That means that other people after me will discuss other aspects, including health of disinfectants. And disinfectants are not like all other chemicals because their primary goal is to kill, and they are considered biocidal products from the legislative point of view. This also means that the EU Ecolabel, as well as the Nordic Swan, excludes disinfectants from their criteria for all-purpose cleaners and also for soaps and similar products. Despite this, we can have some use from what the eco-labeling does, and why do I say this? And that's because disinfectants are in many ways quite similar to cleaning agents or to all-purpose cleaners. Just like those, they end up in sewage treatment plants and waterways, just as detergents do. And of course, from my point of view, disinfectants, they need to do their work without harming the environment. That means that they need to be specific. I said that earlier that they're supposed to kill something, but that means that they should be able to do that without, at the same time, for example, harming fish living in rivers. And what we see from eco-labeling is that there are some very general criteria that eco-labeling usually use, and which also sometimes are part of the CLP or GHS classification scheme. And that is, for example, ecotoxicity for aquatic organisms, and the usual ones are fish, daphnia, and algae, and they take up both the acute toxicity as well as the chronic toxicity. And we also have relevant criteria concerning the biodegradability in an aerobic aqueous medium. It says here that means that it's water where you also have some oxygen, and this is a very, very common criteria for cleaning products or for soap. We also have the criteria of bioaccumulation, and bioaccumulation is the ability of a chemical to build up in especially fatty tissue in the body or in a fish. Those three parts are very usual and very important when you assess the environmental properties of a chemical. And also for detergents as well as disinfectants, the question of anaerobic biodegradation is of importance. Of course, this is speaking from the very general point of view. If I would assess a surfactant, a solvent, or a preservative, or maybe a perfume, but when you look at a specific product, you also will need to have specific criteria. So this means that I will speak from a very general point of view, but it's important to remember that when you are buying a very specific product, you will also need to look into the specific environmental aspects of this product and the ingredients that may be present in the product that we are using. And if I should give some examples of hazardous products, I would first start with the quaternary ammonium compounds, also called quats. And quats are very common as disinfectants, and they have the same structure as many cationic surfactants, and for some of them, or for the difference between a surfactant and a disinfectant is not always very clear. They have different chain lengths, and that has an importance both for the biodegradability and for the toxicity. So we have a very wide variety of quats, but what we can see is that we do find them in the environment, in fish tissue and in sludge, and also in the effluents. And when going into surfactants, as I was comparing them to cationic surfactants, it's important to know that there is a wide variety of surfactants, but if I should be very general, there are 4 different types, and that is where the cationics are considered more toxic than the other ones. The other ones would be anionics, non-ionics, and amphoterics. What you need to remember is that cationics are, because of their higher toxicity, more troublesome than the rest. And they are also, their biodegradability is also often more worse than for the other ones. And as a consequence from the use of quats, the cationics disinfectants are more toxic than ordinary all-purpose cleaners, and this is, as I said before, the reason to why the eco-labels don't want to eco-label products which has antimicrobial and disinfecting properties. And I said that they could be found in fish tissue and sludge, and this was a quite large screening study done in the Nordic countries, was presented in 2014, and this study showed that the cationics, they tend to absorb or adsorb to the sludge and the sediment outside wastewater treatment plants, but you found some of it also in the effluent itself. And when making risk quotient calculations, you could see that the risk quotient was above 1, which means that there is a risk, and that was the case for both benzalkonium chloride as well as the alkyl trimethyl ammonium chlorides, and both of these groups of chemicals are used as disinfectants. And altogether in this survey, it was 17 different quats that was assessed. Other substances which are found in nature and is a problem either for environment or for sludge is, for example, triclosan and nanosilver and other silver compounds. And why I tend to speak about sludge from wastewater treatment plants is because this sludge is, at least in the Nordic countries, used as a fertilizer in the agricultural fields. And that means that the toxic substances coming from disinfectants may end up in the environment, also as runoff from agricultural land, but it could also be a risk for the sediment-dwelling organisms. And it's very, very scarce data with of the toxicity for sediment-dwelling organisms, and this is of course due to the fact that you don't always have to test the toxicity for all different kinds of species when you classify a chemical. And also a third or a fourth group of chemicals which may sometimes be used in disinfectants are fragrances, and almost all fragrances are very toxic, so that means that they can be hazardous to the environment. But as even if I was supposed to speak for the environment, I would like to stress that it's very, very common with people who are sensitized to fragrances, and they should then not be used from this perspective either. So I would like to stop with some general advice on the safe use of chemicals, and that would be that you should start with identifying the problem that you want to solve, and then ask yourself the question, can the problem be solved without chemicals? Because that might be a better solution. And you should choose simple solutions, whether they are mechanical or chemical. You should go for simple solutions. And if you have a exceptional case where you feel that you can't really solve this without dangerous chemicals or could be disinfectants, then you should make a documentation why you have chosen a more hazardous solution, because this is something that you may have use of in a couple of years when you start thinking of, why did I use this one? Why? So it's important that you have practices of how to choose chemicals, and then as a part of this, you should also always make a risk assessment that would typically include both occupational health and environment. And also it's very important when you are using dangerous chemicals, as disinfectants are, that you have controlled use, and that also, of course, includes using personal protection equipment. And then, of course, you should not forget the last step, which may include handling of hazardous waste, because most chemicals are supposed to be handled in that way. And that makes me think of the first picture that I showed you, this river in Sweden. It has a hospital which effluent runs off into this wonderful river, and of course you couldn't tell from looking at the river whether this hospital had been using anything hazardous or not. But let's think about the wonderful nature next time you choose a disinfectant. So thank you very much for listening.
Thank you very much, Elena, for this informative presentation. And so I would like to remind to all the participants to put your questions in the chat box. We will come back to you, Elena, after the other two speakers. So I would like now to introduce our second speaker, Oriane Dumas, Dr. Oriane Dumas. Oriane is a researcher in the Integrative Respiratory Epidemiology team of the Center for Research in Epidemiology and Population Health at the French National Institute for Health and Medical Research. She has 10 years of experience working in respiratory and environmental epidemiology. She strongly contributed to the emerging evidence for adverse effects of disinfectants and cleaning products in asthma, chronic obstructive pulmonary disease, based on epidemiological studies in France and in the US. Oriane, I will now pass you the ball. Just give me a second so that you can move your slides. I think that's done.
Okay, should I move? Yeah, but it's still the. Okay, I can find now my presentation. Okay. So thank you for the introduction. Good afternoon, everyone. So I'm now going to talk about the occupational health risks that are associated with the use of disinfectant in healthcare. So briefly, here is the outline of my talk. Most of my talk will be focused on respiratory health effects of disinfectant and cleaning products, which I will abbreviate as DCP for the rest of the talk. And this is because actually most scientific literature on the health effects of DCPs are on chronic respiratory diseases. But at the end of the talk, I will present recent results regarding other potential health effects of DCP. And then I will end with a conclusion and a discussion of pending questions. So I'm going to talk about the two major chronic respiratory diseases, which are asthma and chronic obstructive pulmonary disease, or COPD. So I just made a slide to briefly introduce these two diseases that not everyone may know well what they are. You probably know what asthma is. It's a chronic inflammatory disease of the airways, which is characterized by attacks of breathlessness with wheezing, called asthma attacks, but also by chronic respiratory symptoms such as coughing. So it's a disease that can appear anytime in life, in childhood, but also in adulthood. And it is quite common. So as an example, in France, 10 to 15% of children have asthma and 5 to 10% of adults. And in the world, 270 million people have asthma. COPD is a disease that typically appears later in life. It is characterized by a progressive and largely non-reversible airway obstruction that leads to airflow limitation, and it is diagnosed by lung function measurements. So it's also a common disease. So as a comparison, in France, among adults older than 45 years, 5 to 10% of adults have COPD. It affects about 300 million people in the world, and currently it's the third cause of mortality in the world. So both asthma and COPD are multifactorial disease. They have many different causes, and for COPD, smoking is the major cause of COPD. But both diseases can be caused by occupational exposures. So it has been evaluated that 15 to 20% of asthma and COPD cases might be attributable to occupational exposures. And there are many different types of agents at the workplace that can cause this disease. And of course, today I'm going to talk more about disinfectant and cleaning products. So it's been about 2 decades that there has been growing evidence for adverse respiratory effects of DCP on asthma and COPD. And currently there is much more data on asthma than on COPD, as I will detail later in my talk. But you can see that a quick search on PubMed on the association between DCP and asthma retrieved about 10 times more results than for COPD. So I'm going to start with asthma. So disinfectants and cleaning products have been identified as a risk factor for asthma about 2 decades ago, started to be suspected at least. And it was first from surveillance data. So it's data from networks in different countries that gather data on cases of occupational asthma, so asthma caused by occupational exposures. And these networks noticed that there was a high proportion of occupational asthma cases in the cleaning industry and in the healthcare industry, and for instance, particularly among hospital workers such as nurses, nursing aides, and cleaners in hospitals. And this network increasingly identified that these occupational asthma cases were caused by disinfectants or cleaning agents. So you may know that another cause of occupational asthma in healthcare has long been related to the use of powdered latex gloves, which was causing occupational allergies and asthma. But since the early 2000s, there was a decrease in the use of these powdered latex gloves. And you can see on this figure that data from French surveillance network show that between 2000 and 2010, there was, on the right, you can see a decrease of the number of cases of occupational asthma related to latex. But on the left, there was in parallel an increase of occupational asthma cases caused by quaternary ammonium compounds that we've already heard about, which are compounds used in disinfectants in healthcare. So after these data from surveillance networks, several epidemiological studies confirmed this observation of an increased risk of asthma in jobs such as healthcare workers and cleaners. And so, of course, after identifying this increased risk in these jobs, the next question was to try to identify specifically which agents contained in disinfectants and cleaning products might be causing the disease. Because, as you know, there are many different chemicals in these products, and to implement prevention measures, we need to identify which are the potential causal agents. So in this table, I summarized all the epidemiological studies that tried to answer this question so far, to identify specific agents which were associated with asthma. So I'm not going to comment on each of these studies. I found 10 studies so far. But you can see that now studies have been conducted in various countries, mostly in Europe and in the US, and in population of cleaners or healthcare workers. And you can see on the column on the right that many different agents have been associated with asthma. And so I tried to summarize this finding on this slide. So the first agents that were identified in epidemiological studies were bleach and ammonia, which were associated with asthma. And bleach still remains the most frequently reported agent in epidemiological studies. And among these studies, the one that focused on healthcare settings and looked at the use of high-level disinfectants, which are specifically used in healthcare, they first found that aldehydes, such as formaldehyde or glutaraldehyde, were associated with asthma. And actually, these agents have been known for a long time as causing agent for occupational asthma. But more recently, some studies have reported that some high-level disinfectants which have been proposed as alternative to aldehydes, such as hydrogen peroxide, or used alone or in mixture with acids, were also associated with asthma outcomes. So now I'm going to present you some results on COPD and lung function. So as I said before, there are fewer studies on COPD, but I'm going to show a few recent studies that have been reported. So as for asthma, the evidence of potential risk of COPD associated with DCPs first came from studies that found increased risk of COPD in people working as cleaners. So this slide shows example of two European studies. So just to tell you how to read the results which are showed on this slide, you can see on this figure there are some measures of the association between working as a cleaner and having COPD. And for instance, a value of 1.69 means that there's a 69% increased risk of COPD for people who work as cleaners. And the straight vertical line is the confidence interval. And so when this line doesn't cross 1, it means that the association is statistically significant. So in this slide, we can see that both of these studies showed that there were significantly increased risk of having COPD among cleaners. And this result was found also when the population was restricted to never smokers and to people without asthma. So similarly, a study in Belgium showed that there was an increased risk of COPD mortality among cleaners compared to other workers. And two studies in the US have looked at the risk of COPD among healthcare workers. One of these, the one on the left with the results reported in orange, did not find a significant increased risk of COPD. But the other one, which is in blue on the right and which is more recent, reported increased risk of COPD among healthcare workers. And recently, there was a study conducted by my group, which was conducted in a population of female nurses in the US. And we looked at the association between the use of several types of disinfectants and cleaning products among these nurses and the development of COPD. And what we found was that use of several disinfectants, so use of glutaraldehyde, bleach, hydrogen peroxide, alcohol, and quartz, were associated with an increased risk of COPD, and these risks were 25% to 36% increase, depending on the type of agent studied. And the last study I want to share on this topic is a study conducted in a European population, which looked this time at lung function decline. So lung function, it's a parameter that is measured by a spirometry that represents respiratory health. So when lung function is low, it means that it is a predictor of poor respiratory health and chronic respiratory disease. And so in these studies, they followed participants over 20 years, and they looked at cleaning activities, and which were either cleaning at home or working as an occupational cleaners. And they found that among women, doing cleaning activities was associated with an accelerated lung function decline. And this was observed both for cleaning home and working as a cleaner. So I'm going to move briefly to the other potential health hazards. So as I said before, there's much less studies on other diseases that are not respiratory. But yes, Ariana, it's almost my last slide. I will finish soon. So briefly, there are a few studies that found that use of disinfectant in nurses was associated with adverse reproductive outcomes, such as preterm birth, spontaneous abortion, reduced fecundity. There's also one study that suggested potential cardiovascular health hazard, but this is just one study, so it should be interpreted with caution. And another potential health hazard is related to the fact that disinfectants contain also endocrine disruptive chemicals. And there's not many studies on this specifically in disinfectants, but it may be also associated with health hazards. So to conclude, there is now strong evidence to support a link between DCP exposure and asthma. Also, evidence to support a link with COPD now is accumulating. And for other potential health effects, I think that additional studies are needed, but it should definitely be examined. Of course, there are many pending questions, and I think the most important is how to now implement prevention, and in particular in healthcare settings where we cannot just stop disinfecting, of course, because it's needed for infection control. So for that, we need to clarify the agents which are really harmful for respiratory health. and also start to evaluate potential strategies for asthma and COPD prevention, which could relate to the use of protective equipment or ventilation. Another idea would be to limit the use of sprays, which have been shown to increase exposure by inhalation. And I know some hospitals already have tried to limit that. And then there's the question of safer alternatives. We've heard in the talk before about green or environmental friendly products, but they also need a health safety evaluation, because it's not because a product is good for the environment and is based on natural ingredient that it's good for health too. And perhaps new methods of non-chemical disinfection should be investigated. Thank you for your attention.
Thank you very much for the presentation. Again, I encourage the audience to write their questions in the chat box, so we can come back to it after our next speaker. That I would like now to introduce Matthew Wunsch. He is a Senior Project Team Leader at Public Health England. Matthew has worked at Public Health England for 10 years. During this time, he has investigated the potential mechanisms by which gram-negative bacteria adapt to the presence of biocides and disinfectants. And a proportion of this work is including trying to understand whether there are any common resistance mechanisms for disinfectants and antibiotics, and thus if there is cross-link between biocide adaptation and an increase in antibiotic resistance. His research has involved the invention of many methods to investigate this link. So he now works primarily on mechanisms of antibiotics resistance, but lectures also on the importance of disinfection to both students and healthcare workers. Matthew, I will now switch to your presentation and pass you the ball. You can start.
Okay, thank you. I hope everyone can hear me. Good afternoon from a sunny England. I'm going to talk something a little bit different about in clinics, the use of disinfectants and how that might lead to cross-resistance to antimicrobials, particularly antibiotics. So obviously, as we know, multi-drug resistant infections are on the rise. So antibiotics are failing to take care of these infections, and this places much greater pressure on infection control procedures, and obviously a big part of that is biocide disinfectants, with the proviso that prevention is better than cure. So in terms of bacteria, gram-negative bacteria in general tend to be more intrinsically resistant to a multitude of disinfectants than gram-positives. The exceptions are Mycobacteria tuberculosis, another mycobacterium due to their large waxy cell wall, and also the spores of things like Clostridial species, Bacillus species. But in general, gram-negatives are more resistant than gram-positives. So some of the questions that we're interested in is, obviously people are very much interested in studying levels of antibiotic resistance, but they don't seem to do that for biocides. So why is that? Obviously, because we're just not seeing it, are we not looking for it, or is it just not there? Have bacteria become more tolerant to biocides as we've begun to use increasing amounts of them? And mainly, I guess point number 5 is probably the most important one. Fine, we can make bacteria that are more tolerant to specific biocides, but actually, does that matter? Because we're very much interested in in-use concentrations of biocides. With biocide, the difference between biocides and antibiotics is we can get away with a much higher level because we're not asking to put them inside a body or something like that. So we can get away with using a much higher level. So does the current level of biocide resistance actually matter? Now, for those of you who know about antibiotic resistance, you'll know that there are 4 main mechanisms for resistance. There's cellular wall impermeability, so i.e. can the antibiotic get into the bacterial cell? If it can get in, does it just get simply pumped straight back out again? That's known as efflux, and the bacteria will use specific mechanisms called efflux pumps for this. If it doesn't get effluxed, then obviously antibiotics have specific targets. Again, another difference between biocides and antibiotics. Disinfectants work on multiple targets. The exception is triclosan, which there are resistance mechanisms out there. But for antibiotics, has a specific target. So, for instance, aminoglycosides work on ribosomal subunits. If we change that target, the antibiotic won't work. And equally, the bacteria itself is capable of producing enzymes that will degrade specific antibiotics, for instance, the beta-lactams. Bacteria can produce an enzyme called beta-lactamases, which will degrade the antibiotics. Now, for disinfectants, the last two aren't that prevalent. There's a couple of studies out there on enzymatic degradation. Unless you're talking about triclosan, target modification isn't a problem. So it's generally the first two, the impermeability and the change and the efflux. So also for biocides, as well as antibiotics, biofilms tend to play a role. And for biocides and disinfectants, we generally tend to attack bacteria in a biofilm form. It would be on a surface, in a wound, etc., etc. So we are asking the disinfectant to work against the biofilm. And this diagram is a little bit small, I apologize, but as you can see, as we move from a planktonic or a free-swimming form of bacteria into a biofilm, the concentration required to eradicate that biofilm goes up. So if we look at the Pseudomonas aeruginosa, we have a value of 8 for the planktonic, but it goes to greater than 512 for a biofilm. And this is important in terms of mixed species bacteria, biofilms, because in something like wounds, we expect there to be not just one species of bacteria there, there'll be multiple bacteria species there. And so we have a 4 species bacterial biofilm here, 2 gram positives, 2 gram negatives, and up to 4% of chlorhexidine, which is a topical antiseptic, very widely used in many products. We can show that above in-use concentrations of chlorhexidine, the gram negatives, the Klebsiella and the Pseudomonas will survive. Gram positives, not so much. So in biofilm form, like for antibiotics, disinfectant resistance is increased. Now, we have access to a group of strains that were isolated before the widespread use of disinfectants. These are called the Murray strains. Nothing to do with this tennis player here, but due to a Canadian clinician. Now, if we forget about the spider diagram on the left and look more at the panel on the right, where it says B, we've got a white set of bars, which is the pre-antibiotics isolates, and the black bars are more modern. These are Klebsiella isolates. This is again against chlorhexidine. We can see that for the pre-antibiotic era, we have 2 subgroups. One that are more akin to the modern set, but a subset which are very much less tolerant to chlorhexidine. Now, what has happened to that? As chlorhexidine has been more and more widely used, has this subset died out, or has it actually adapted to become more tolerant? Where this relates to antibiotic resistance, this is again about chlorhexidine, and again in a bacteria called Klebsiella. We can artificially make Klebsiella strains which become more tolerant to chlorhexidine. We can do that. And as a consequence of that, actually, we can make these strains become resistant to an antibiotic called colistin. Now, for those of you who don't know, colistin is a very, very important antibiotic, widely used to treat multi-drug resistant infections. It's called a last line resort antibiotic. It's not a very nice antibiotic. The side effects are pretty bad, but we kind of need it now because we're running out of antibiotics. So to actually generate resistance to this is a bad idea. And we can show here from this study that low levels of exposure to chlorhexidine can give rise to colistin resistance. How does it do that? Because the bacteria will mutate specific genes. And without going into the complexities of this, it's a two-component system. Now, colistin is a cationic compound. It will work by binding to the anionic membrane on the bacterial cell wall. So you can imagine if we make that membrane less ionic, more neutral, the colistin itself won't bind as strongly and won't work as effectively. And that's effectively what these mutations will do. Now, in general, colistin resistance is quite easy to generate, but it's often associated with what we call a loss of fitness or virulence, i.e. that the bacteria are fine when you've got a selective pressure, i.e. in this case colistin, but once you remove that selective pressure, they're much weaker in terms of growth, and thus they'll be lost because they'll just be outcompeted by those strains which are more susceptible. But there are examples of where this doesn't happen, and this is what we need to be more aware of. So there are specific examples here where we have generated Klebsiella strains which are become more tolerant to chlorhexidine, have developed colistin resistance, and don't appear to have lost this kind of fitness as measured by the parameters that we've used. So we've tried to move on to more clinically relevant examples. So here we have taken a sink trap in a hospital and attached it to a rig system in our laboratories. And this is testing another antiseptic called octenidine, which is beginning to be more widely used because of high levels of toxicity to things like chlorhexidine. And the sink trap is basically that water-filled bit in the sink where you use it just so that you don't get the smell of all the drains coming back up through the sink. And bacteria love it. They will grow like happily there, lots of water there, etc., etc. So we try to mimic a study where if people have like showers or something like that with an octenidine-containing body wash, things like skin decolonization, what does that do to the community down the sink? Well, it changes the population. We get some species will die out and others will become more prevalent. I'm just looking at the gram-negative population here. And we can show here in the graph at the bottom that some strains will actually increase their octenidine tolerance. Right, this is bar at the top is Pseudomonas aeruginosa, very common in hospitals. And we can generate resistance to in-use concentrations of octenidine by this. But there are other unintended consequences. So I'm just looking at 3 species here: Pseudomonas aeruginosa, Enterobacter, and Citrobacter, again, all gram-negatives. Yes, for Pseudomonas, we get that increase in octenidine resistance, but there's no biocidal cross-resistance to other disinfectants, no antibiotic resistance. But for Enterobacter and Citrobacter, we don't actually see a great increase in octenidine tolerance, but we do get that antibiotic cross-resistance to specific antibiotics. So for Enterobacter, things like ciprofloxacin, which again, widely used to treat Enterobacter infections. And these again are down to specific mutations in regulators of these efflux pumps. Remember I told you before that efflux is quite an important resistance mechanism for biocides as well. And with the ones highlighted in red, we've got these genes called RAMR and MARA, and these act basically as regulators of a multi-drug resistant efflux pump called ACRAB. TOL-C, which spans both membranes and gram-negatives, is quite prevalent and important in a wide variety of species. So again, we're showing that in a clinical environment, you can potentially develop, by putting disinfectants to drain, you can develop antibiotic resistance in bacteria. So perhaps we need to review some regulations about what we tip down our sinks or showers or whatever, because this can lead to increased antibiotic resistance. So in conclusion, just going to mention obviously the biofilms, they're more resistant to specific disinfectants, and we can get above those clinical concentrations. The more modern strains of Klebsiella appear to be more intrinsically resistant to chlorhexidine as well as other disinfectants. We can select for cross-resistance to colistin as well, which is very worrying. And we can select for particular species by continuous sublethal exposure to specific disinfectants. This was done in the sink traps. And we can also generate strains, again, which have increased resistance to specific antibiotics through mutations in efflux pump regulators. So that was just a very whistle-stop tour of some of the work that we've done. And obviously, I'd like to acknowledge all these people here. And many thanks for listening.
Many thanks, Matthew, for this very interesting presentation. I would like to go through some questions we have for our speakers. I'll start. I'll go back to Anna. I would like to start from you. So we have a question regarding triclosan and the fact the availability and use of this biocidal products containing triclosan on the EU market was banned since the beginning of 2017. And the question is if you think that there are still disinfectants that contain this chemical. And this is a question also relevant for our project, because if I remember correctly, we had one or two products in Brazil that had triclosan, but I think it would be nice to hear more from your experience on this.
Okay, so thank you. I would say that of course the data that I had that you find triclosan in the environment is older than well, it's about from 2016, but as you have a very slow degradation, you can find it in the environment even if the use has been banned. And I am sorry that I don't have the exact knowledge of whether it's still in use as a disinfectant in other parts of the world, but maybe someone else can answer that question better than me. So thank you.
Okay, thank you. We see if also other speakers would like to comment on that. I have now a question for Oriane. The question is from Susan, and is if you can comment on the recent report from ANSES in France about poisoning from disinfectants use related to COVID-19. And we also have a link to a website here, but I don't know if you're aware of this recent report and if you would like to comment on it.
Yeah, I think I've heard about this, that maybe there was an increase in poisoning because people are at home and including with children. And of course, I think that's classic risk of having disinfectants at home, but since people are more at home now, there might be more poisoning. I'm not sure what kind of comment. It's true that it's not the kind of health effect that I usually study, so maybe I don't know if the person wants to clarify the question.
Okay, we can see if we get more about this question also in the chat box. In the meantime, we can move to a question for Matthew from Gabriel. So he's writing, in Brazil, chlorhexidine is widely used as an antiseptic for non-damaged edges and regions of dressings. Can this negatively influence the healing time due to this resistance that has been observed?
In short, no. Actually, I mean, one of the questions I do get asked a lot is should we still be using chlorhexidine? Yes, absolutely. Chlorhexidine is still a very, very effective antiseptic. There has been little, actually, this was all laboratory, so at the moment we have yet, because we haven't really looked for it, we haven't really found any clinical evidence to link chlorhexidine exposure to colistin resistance yet. But as I said, people aren't really looking for it. But No, I have not read any or come across anything that says that chlorhexidine is bad for the healing time of that. And in terms of the wound healing, actually, it just tends to be the poor penetration into the wound that actually is what's causing the problems more than the actual resistance to the particular disinfectant at the time. If that answers your question, I apologize if it doesn't.
Okay, and I also have another question for you from Dorota. You said in your conclusion that exposure to continuous sublethal levels of disinfectants selects for particular species. And the question is how we can improve the situation in the hospital settings.
Yes. So one of the things that you can probably do is to rotate your disinfectants to stop these kind of build-up of low levels of disinfectant, particularly in drains and things like that. So rotation, but also just be aware of exactly what you are tipping down your sink, and maybe alternate out where you do washing or something like that. It's certainly true that specific, from studies that we've done, specific sinks have bigger problems than others due to actually what goes down there in regular quantities. But generally, cyclical switching of particular disinfectants will help mitigate this more. And I hope that answers your question.
Okay, thank you. I also, we don't have a lot of time for the questions now because we run a bit over, but I also encourage the participants to follow up either individually with the speakers or to keep writing us the question, as we have also a second Q&A session later on. So thank you very much again to Elena and Oriana and Matthew. So we would like now to move on to the next session. And our next speaker is Marion Jaros from the Environmental Protection Office of the Municipality of Vienna in Austria, where she has been working there for more than 20 years on the assessment of chemicals, soil protection, nanotechnologies, environmental education, and climate change. She is the head of the Viennese working group OKKAUF Wien for disinfectants and for nanotechnologies, and a member of the expert group developing the Viennese climate protection program. She is also a member of several working groups at the federal level as the REACH platform and working groups for endocrine disruptors for the development of the Austrian Nanotechnology Action Plan and other health programs. As you will learn from our presentations also later today, the work that Marion will be presenting is also what inspired our project SAICM 2.0 and allowed us to work on this topic at global level. So now, Marion, I will put your presentation and give you the floor. Just give me a second.
Yes, hello. So also a very warm welcome from my side. I hope everybody can hear me. Yes, I want to introduce to you a database for disinfectants called VIDAS that we developed in the city of Vienna. So this database was implemented and developed within our program for green public procurement in the city, which was implemented 2 decades ago with the goal to purchase all goods and services in the city according to ecological considerations. And this is a big goal. In Vienna, we have a budget of about 5 billion euros per year. And so we just implemented 26 working groups with more than 200 internal and external experts, also from universities, just to create eco-criteria lists for all the goods and services we purchase. and also for disinfectants. What might be also interesting for you, all the results of our work you can find at this website from Eco by Vienna, and all these results are also binding for all the departments of the city by an executive decree. So all our purchasers have to use these results. So next slide. Yes, here you can see just the participants in our working group. We work together with manufacturers of disinfectants and also of active substances, also from Switzerland, where we got some confidential data about active substances. We work together with the Ministry for Social Affairs and for Environment, with the Austrian Workers' Compensation Board, who also finance the work, a big part of our work. We work together with hygiene experts from our hospitals, and also with eco-toxicologists as Dr. Klade, who is the mastermind behind our database and who also developed the evaluation scheme together with some international experts. And yeah. And when we started our work almost 2 decades ago, the atmosphere in our working group was not so good. It was a little bit tense because the companies, the manufacturers of the disinfectants, they did not like that we just tried to focus on the negative adverse effects of their products, and the hygiene experts, they were afraid that we will recommend disinfectants that are more ecological friendly, but maybe less effective to save lives. And so at the first we had a discussion process, and we just set up some theses. And one was that we all agreed that disinfectants, of course, are indispensable in hygiene risk areas, and that, of course, there are some disinfectants that show relevant impacts on health and also on the environment. And in a second step, we said, yes, we will find some disinfectants also in specific areas and applications that have enough difference in their toxicological profiles that a substitution is justified. And that these best products with a low toxicological impact will also be affordable for the city. And so we started in a first step. We just collected all the safety data sheets from the products that were used in the city. That's more than 100, and also some others from the market supply. And then, okay, we tried to compare them according to the classification of the hazardous properties, and we found out that this is almost not possible, because we had at this time a very high lack of data, and we saw that companies just classified the same active substance very, very differently. And then a lot of disinfectants are sold as concentrates. And no, you know, the dose makes the poison. And if you have a concentrate and they dilute it during the application 200 times, then it's another thing. You have other properties. And so we found out that that we need a database just to make a proper and a transparent assessment of disinfectants. And yes, and so we, I can just go to the next, I think. We just developed our database. And this database is industry independent. So no company ever paid us some money for the development. It's user-friendly because we work together with hygiene experts and purchasers who now shall use this database and uses it. And so I think we just did a good work in this field. And it's also without charge. And we also did an English translation. And so you can find the database with these links below in German and also in English, and also training videos. And now the database includes the toxicological profiles of more than 200 ingredients, also including the source references. And the main source today, of course, is the ECHA, the European Chemical Agency. And we also integrated more than 300 disinfectants for surface, instruments, laundry, dishes, hands and skin mainly, from the Austrian and mainly the German market. But some of them are also sold in other continents. And yeah, there we just put in the data from the manufacturers, from the safety data sheets about the composition, about spectrum of activity, always independently certified. And in the next step, Dr. Klade and his team just developed an evaluation scheme for the database. And here you can see the adverse impacts that are assessed in the database. It's acute toxicity, especially for the respiratory tract. We already heard before that this is very important. Irritation or corrosivity for the skin, and the allergenic potential for the respiratory tract and for the skin. CMR effects, very important, we think. Also for pregnant women working with these substances. And also the behavior in surface water, the toxicity for aquatic life, acute and chronic. And this slide I cannot explain in detail because lack of time. But what I want to say is that for every hazard statement that is important in the field of disinfectants, we assigned an assessment number from 1 with almost no hazard potential to 7, a very high hazard potential. And also we just assigned data gaps with a question mark. So in the whole database, you always can see if an assessment is done with a good or a not so good database. And I think this was also a good decision. And yeah, and we just in a next step made some sort of report for every ingredient in the database, assessing the dangerous properties in these 6 categories. And we have also in the database an overview over all the 200 profiles, toxicological profiles of all the ingredients. And I think that this link here that you see will help you all over the world just to know with actual data from the ECHA which ingredients are most dangerous and which ingredients are less dangerous. And with the assessment scheme, with the calculation model, we were then able to make also some reports for every disinfectant inside the database, also with assessments for the 6 categories, and for disinfectants containing alcohols, also the flammability. And we transferred the assessment numbers into a color code. And bright yellow means low hazard, and dark red means high hazard. And you see also the question marks where the assessment was done with data gaps. And so it is possible for you by considering the concentration of every toxic ingredient in all these disinfectants, and by considering also the concentration in the working solution, just to give you an orientation which products are in a specific field with a specific spectrum of activity, those with the lowest impact on health or environment. And all the hygiene experts now can choose by themselves. For instance, I'm in a neonatology, and I don't want to use disinfectants with CMR effects, and no disinfectants with allergenic potential. And then you can just rank your list that you just got in the database with these specific applications, and then you can just choose the best products on the market. And now, as we just finished the database the first time, we just started to make some trainings for the purchasers in the city for disinfectants, not only for the hospitals, but also for hygiene experts in the kindergartens, in schools, in official swimming pools, yes, and then we just also made some recommendations which disinfectants might be better to use with a lower hazard potential. And then 2 years or 3 years later, we did our first monitoring and just looking at the situation, which disinfectants are used in the different departments, and is there still a potential for substitution. And we found that the toxicological product profiles of our disinfectants are quite good, but we also found some additional potential for substitution. For instance, the Viennese schools at this time used antimicrobial soaps with triclosan. So, and after our intervention, they just switched to ordinary soap. And we had also in the official swimming pools, there was used disinfectants with CMR properties. And we could not find a better one because they needed some specific properties. But in a first step, we could reduce the amount that was used by 50%. And then after a year, the manufacturer could change the formulation. And so I think it was really a good success. And another success was that our Department for Health Service, they had set up a guidance for the selection of effective disinfectants, and they a long time recommended the use of aldehydes. And after taking a look into our WIDIS database, they decided not to recommend aldehydes anymore. So they set up a new guideline, and I think this is also a good success from the database. And here you see the benchmarking that and you can see the benchmarking that Dr. Klade did, comparing every disinfectant that we use to the worst disinfectants according to her toxicological profile and the best, and also taking into account the amount of these hazardous chemicals. And this was a very good communication strategy, and so we could just change a lot of disinfectants to better ones. Yeah, here is an overview how much chemicals, dangerous chemicals, we avoid comparing to the most dangerous disinfectants on the market, and also the potential for substitution. And there you can see the column is very low, so there's not much potential anymore from our side. And the hospitals just made a list of recommended disinfectants working together with us and with the WIDES database. And 90% of the cases, this list is used. And now we just compared the disinfectants that were used at the beginning of the project with a high amount of toxic and sensitizing and CMR and ecotoxic substances to the products from the recommendation list. And yes, we could really avoid most of these toxic substances. The only problem is that we couldn't avoid all ecotoxic substances at this moment. And we still use some quaternary ammonium compounds today. And there is also a decree from the Austrian Labor Inspectorate for hand disinfectants that are also allowed to be used by pregnant employees. And this decree recommends the use of the WIDES to find out if the product fulfills the criteria. And since this decree is used in Austria, the WIDES database is famous in whole Austria, and we have a very close cooperation with the companies. And if some product does not fulfill this criteria, the companies just change the formulation. And we have now we have a very high amount of perfume-free products and with low hazard potential. And the WIDES database is also recommended by the WHO, by the European Commission, by ICLE, and also by the European Agency for Occupational Health. And we also got an award this autumn for the database. And yes, I hope that the database can also help you. I invite you to take a look inside. And I also invite disinfectant manufacturers just to integrate their products. They only have to meet some basic criteria that are specified on our website. And yeah, and then I just ask you for corporations. We are also very interested in optimizing our assessment rules. So yes, please ask me some questions, and thank you for your attention.
Thank you very much, Marian. It is really great to see the journey of the WIDES database and its positive impact in the city of Melbourne, not only. And so yeah, I would say that this has an impact also beyond Austria with our project. And another key person that is behind our project is the next speaker, Anders Wolmstedt. He is a PhD chemist at the Västra Götaland County in Sweden. But Anders is also the chair of the board of Healthcare Without Harm Europe, and is part of our expert working group on disinfectants. He coordinates the chemical management in Västra Götaland County from the aspects of health and environmental protection. And Anders' work involves setting up and evaluating demands in procurement and educating employees about the safe management of hazardous chemicals. He has also been involved in risk assessments of hazardous chemicals for over 15 years and initiated the so-called National Substitution Group in Sweden that is still active. And he's employed by the Occupational Health Services of the county and involved in promoting healthy lifestyle for a sustainable future. He will present together with Jessica Ikonen, who is not new to our webinars. Jessica is an infection prevention control nurse at the Saarbrücken University Hospital in Gothenburg. And as a registered nurse, she has worked in infection prevention and control for almost 20 years now, both in the United Kingdom and Sweden. And within her role, she participates in procurement and advises on matters relating to infection prevention and control. She's a clinical nurse, specialist in intensive care and anesthesia care. So, Anders, I will give first the ball to you, and then once you're finished with the presentation, I will pass it to Jessica.
Thank you. Do you have my slides? Or... there it is. Well, welcome everyone. Can you hear me? Just let me know.
Yes, we can hear you well.
Okay, at least you. Yes, really I have to put it on a map. It's the west coast of Sweden. It's actually the biggest employer in Sweden. We have 53,000 employees. We have 19 hospitals. So it's a big region. We have a lot of hospitals and dental care, things like that. And of course, we use huge amounts of disinfectants. And okay. Well, disinfectants, you want to have an antimicrobial efficacy, of course, as good as possible. The disinfectant should do its work, and we follow that by the EN standards. That's actually one of the issues that Jessica is following very carefully. And of course, we want to have as low occupational health impact as possible, and of course, environmental impact as low as possible, and of course, to an affordable price and cost. And to achieve this, you have to set up a panel of demands in your procurement and follow them up really carefully. And as you all know, we have the COVID-19 issue now these days, and it has a huge impact on disinfectants. We can see both in healthcare and in the society that the use of disinfectants has increased dramatically, and so has the price, I can tell you. And we now face a lack of disinfectants in healthcare. We have been struggling with that a lot the past weeks. I think we now, at least in our region, have a situation in some kind of control, but I mean, we have a problem there. Another problem is that new disinfectants with unknown properties are all of a sudden in use. So I really want to emphasize that quality control, health and environmental demands on disinfectants are extremely important now to avoid future problems. And when I see pictures like this in newspapers and TV and Facebook or whatever, I get really nervous. I mean, does it have an effect on the COVID outbreak? Most likely not. And what are the long-term consequences? I mean, look at these guys. They don't even wear masks. I mean, this is crazy. However, we do two separate procurements of disinfectants in our region. One is for skin and surfaces. It could be hands, could be skin for the patients, before surgery, could be for surfaces like desks, benches, beds, whatever. And the other procurement is for medical equipment, where we have sensitive surfaces like endoscopes, certain probes, etc. I will focus on number one, and I think Jessica will mention more about number two. The number one, where we procure disinfectant for skin and surfaces, we first of all, we have the surface disinfectants. We have different disinfectants for that. It could be not just ethanol, it could be ethanol together with a small amount of detergents, because then you have a cleaning effect and a disinfectant effect. If you just use pure ethanol, it's not that efficient. And we have different kinds of alcohol depending on the surface we are supposed to disinfect. And then, of course, we have the hand sanitizers, and as I said, we also have disinfectants for the patient to disinfect the skin prior to surgery. Together with this, we procure soap, and it should be as gentle a soap as possible, because it's very important that you take care of your hands when you are in healthcare. And we also procure skin lubricants. This is mainly for patients, actually, but it can be used also for our staff. And to set up all the demands for this, we used to have a project group with people from different disciplines. First of all, we have the project leader who knows everything about the legislations around procurement, and then we have a chemist, mainly me. We have hygiene experts, that's Jessica and our colleagues. We have dermatology experts, and we also have personnel working with the disinfectants out in the hospitals. And the reason that we have all these experts in one group is that we want to make sure that we get the efficient disinfectants, but it should not harm the environment, should not harm the employees. And we work very closely to the occupational health service. We have doctors there who can examine your hand if you have some problems. And of course, if you use wrong disinfectants that harm your hands, you can have small wounds or blisters on your hands. And worst case scenario, if the problems are really bad, you cannot even work in the hospital. And I can say hands is the most valuable tool we have in healthcare. So we have to take care of our hands. When we set up the sustainability demands, we used the wizard from the National Agency for Public Procurement. This is just a print screen from their website. You have the website there. Yes, thank you for putting that on the chat box. But there's a very complicated Swedish word. It's very Swedish to put several words together in a long row. But I recommend you to click on that and take a look. I will just briefly explain how it works. You can choose the level of demands. You can have basic level, you can have advanced level, or spearhead level. And to exemplify that, you can look at the bottom. If you have the basic level, you say that you should not have a sensitizing product. The product should not be characterized as sensitized. But if you make the advanced level, it should not contain sensitizing substances, regardless that the product is not labeled sensitized. And if you have chosen these kind of levels, you print out the wizard and you get something like this. You can read here that ingredient substance shall not be classified with the following hazard class. And in this case, it is H317 and H334. And this document, you can also get proposed verification, and you can also get proposed follow-up strategies. I had a call with them on National Agency of Public Procurement yesterday, because when you print this document, it's kind of ugly, but they're actually working on making it more readable or more beautiful, actually. One thing that you should keep in mind is that this wizard is not just for disinfectants, it's for cleaning chemicals as well. So you can use it also when you procure cleaning chemicals and cosmetics. Ariana mentioned the National Substitution Group. That is a network between regions and universities where we can share good examples around chemical substitutions. And we can also share experiences. That's something we do quite often. And when it comes to procurement, we want to harmonize our sustainability demands in procurements. And by that, achieve a market transformation. And if I look back in the mirror a couple of years ago, it has actually been a market transformation. If I look at the cleaning chemicals, disinfectants we have today, is much more health and environmental friendly than some years ago. When we do the procurement, we invite the suppliers individual for face-to-face meetings. Well, now we have COVID-19, so try to make it on the web. But anyway, it's very good to have them face-to-face in the room. And we use request for information. I don't know how familiar you are with procurement procedures, but the request for information is that you can send out the questions, or more or less the questions you are going to ask for in the tender beforehand, and they can reply to it. And we also have a period where we have Q&As. The suppliers can send in questions, and we answer them. And I can share some experience with you. We use mainly alcohol for disinfectants. We prefer ethanol before isopropyl due to health issues. Chlorine is something we almost never use, only when it's really necessary, and that could be an outbreak of Clostridium difficile, for instance. We have now started to use something called accelerated hydrogen peroxide more and more as a substitute for Vircon, for instance, and it seems to work very well, and I think we will follow this in the future. And then we have some no's. We ban sprays for several reasons. Mainly because you can inhale these small aerosols and could get health problems, as we had previously. We have no perfume. To me, I cannot understand why you should have perfume in disinfectants. For me, it's totally understandable. PHMB is a complicated compound. We don't use it in disinfectants for surfaces and skin. We can have it in certain bandages for healing wounds. Quartz we don't use at all, and of course no nano silver. And here are some other experiences. I can advise you to ask for ingredients when you procure disinfectants. Remember that the safety data sheet does not tell you the whole story. The substances listed in the safety data sheet are only those that they have to declare on the safety data sheet. But you can ask for a list of ingredients. That's more easy than ask for the complete recipe, of course. So that's an advice. Ask for the list of ingredients. And of course, follow up your tenders. Did you get what you asked for? That's important. And learn from others, share experiences, and harmonize demands, and you can make this market transformation. And I think it's a pity that we can't meet face to face now, but I do hope that we can share experiences after this webinar, and I know Ariana has some ideas on how to keep up this discussion so we can share experience and maybe really make a market transformation and stand in front of the market with sort of one set of demands. And also advise you to have a continuous dialogue with suppliers. Follow what's happening in the market. There could be some new things coming up. It could be really, really good. And check out for small and medium-sized enterprises. And in the light of in the shadow of the COVID-19 crisis, it's really important to see what kind of disinfectants can be produced within your country. And of course, use the right disinfectant for the right purpose and mind the importance of skincare. And regardless what kind of disinfectant you're using, follow the hygiene routines. That's extremely important. So, and I can see Mariana said I have only 1 minute left. And by that, I said thank you for listening. And I pass it over to Jessica.
Thank you, Anders. I give the floor to Jessica and switch to her presentation. Jessica, you can unmute yourself and start with the presentation. And I will then give you 2 examples of medical devices that are challenging to decontaminate and which disinfectant we in region Västra Götaland use for this. So this is a table, and the first column in the table shows which type of contact the item, the equipment or medical device will have with the patient. The second column shows the level of decontamination required, and the last column shows the method of decontamination used to achieve the level required. And whenever possible, the preferred method of disinfection is using thermal disinfection or moist heat. And for an item to be disinfected, it first has to be cleaned. And for an item to be sterilized, it first has to be cleaned, disinfected, and then sterilized. So as we're looking at the first column here, if the item is in contact with intact skin, it really only needs to be cleaned. And you can do that with detergent and water. However, if the item is contaminated with blood or body fluid, or if there's an increased risk of contamination, that could, for example, be handles on a walking frame that is shared between patients, then it would need to be disinfected. Now, for a bedpan, we would use an automatic bedpan washer disinfector because we want to use thermal disinfection because it's possible for that item. But if we do have to use disinfectants, then we would use alcohol-based, Vercon, or accelerated hydrogen peroxide. That was the one that Anders talked about earlier. Now, if items is in contact with mucous membranes or contact with non-intact skin, they need to undergo high-level disinfection. And in most cases, these items are contaminated using thermal disinfection, which is basically, like I said, using heat, in an automated washer disinfector. But high-level disinfectant is used for items that don't tolerate heat. Now, items that penetrate skin or mucous membranes or enter the vascular system or in other sterile body areas, they need to be sterile. And the method used is steam sterilization, and this should really be done at the sterile services department, which you do have in-house at the hospitals. Now, items, equipment, and medical devices should be decontaminated according to the manufacturer's instructions and with cleaning solutions and disinfectants approved by the manufacturer. That's why it's important that when you do purchase equipment and medical devices or items, to take into account which disinfectants are available already procured within the region. And this is so that you don't end up with an item that you don't have any methods or disinfectants to decontaminate the item with. So heat-sensitive flexible endoscopes and ultrasound probes, these are medical devices that are challenging to decontaminate, and that's because they're made of very sensitive materials, so they don't tolerate heat very well, or not. They can also be difficult to find disinfectants that you can actually use that won't damage the material. So heat-sensitive flexible endoscopes, they require high-level disinfection, and they don't tolerate high temperatures, so a chemical disinfection is needed. The endoscope is manually cleaned with an asymptomatic detergent prior to processing in an automated endoscope reprocessor. Now then, enzymatic detergents used have to be compatible with the disinfectant that is being used in the reprocessor. In the automated endoscope reprocessor, the endoscope goes through both detergent and disinfectant cycles, and asymptomatic detergent is used for the cleaning cycle, and then followed by a high-level disinfectant, and we're using peracetic acid. Now, orthophenaldehyde is available within the region because in case if the reprocessor would break down and you would manually have to disinfect the endoscopes. But which obviously, try not to use it because you should use the automatic reprocessors with a peracetic acid, but it's there in case we would need it. Now, we don't use glyceraldehyde at all anymore, and it's probably not been used for the last 10 years. Glyceraldehyde was phased out over a period of time, and was doing that because we then replaced endoscope reprocessors with reprocessors that would use peracetic acid instead of glyceraldehyde. And in some cases, instead of buying new reprocessors, we were able to rebuild the reprocessor to be able to use the peracetic acid instead. Now, ultrasound probes have a very sensitive surface, and this limits the choice of detergent and disinfectants that are compatible with the probe. And as mentioned before, depending on where the medical device is to be used, that will determine the level of decontamination required. So for non-invasive ultrasound probes, they are in contact with intact skin, so they will need to be cleaned between patients. But if there is increased risk of contamination, or if they're in contact with body fluids, then they would need to be disinfected. And for this, we would use 45% isopropanol. And this is used because it's kinder to the material because of the lower strength of alcohol. The semi-invasive ultrasound probes need to be decontaminated using high-level disinfectant. And the first choice from an infection prevention point of view is to use an automated disinfection process. And we use hydrogen peroxide or peracetic acid, depending on the automated disinfection system used. So there's so transvaginal and transrectal probes, they will have one machine that will be able to reprocess those, and they would use hydrogen peroxide. And then for the transesophageal echocardiographic probes, they would use a different machine which would use peracetic acid. Now, obviously, it might not be feasible for all departments to purchase the automatic system, so some manual high-level disinfection procedures are also used. And then we would recommend that you use peracetic acid for this. Unfortunately, it's not very quick and not really practical to use the peracetic acids. So we are currently looking into other disinfectants that might be more easy and more practical to use. But this work is still ongoing and probably put on hold for a little bit now because of the coronavirus pandemic. So this was really my last slide. So I would say thank you very much for listening. Thank you very much, Jessica. Great. I think we always need to stress the importance not only of sustainable procurement, but also to combine it with sustainable consumption, decontamination strategy, and safe application of disinfectants in hospital settings. And I remind again to our audience to write their questions in the chat box because we will now move to the presentation about our SAICM project. And so as now you all know, the project aims to promote the use of safer and more environmentally friendly disinfectant in healthcare setting, but of course, without compromising hygienic and occupational health standards. And this work, we hope that it will help to implement the WHO chemicals roadmap and UN strategic approach to international chemicals management, the so-called SAICM process. So in essence, through the project, we are analyzing hospitals' procurement practices and trying to identify the main barriers to the purchasing of more environmentally friendly disinfectants. And as you can see in the process of the project, the engagement was done in form of a survey and follow-up interviews and a subsequent benchmarking of disinfectant products. We had more than 80 responses to the survey from almost 20 countries, so it was a really global. We had a really global response, and we analyzed more than 160 disinfectants products used in these hospitals. All the participants that shared their product information received a compact analysis of their hazard profile, as well as the estimated potential to substitute these products. With the follow-up interviews, we produced 6 case studies, and Manfred will present some information about this in his presentation later on. And all these learnings and recommendations have been compiled in an interim report that will be released after this webinar for open consultation. So the survey results have been presented already in our last disinfectant webinars, and I won't go through it today. If you haven't seen our last webinar, I would encourage you to listen to the recording or read our interim report, or both. But still, I would like to just show a couple of slides from the survey that I think would be interesting to see the results, and hopefully will also helpful to have a discussion about sustainable procurement and the need for harmonized procurement criteria. So as you can see in the slides, although 2/3 of the respondents declared that infection control, occupational health, and environmental managers are involved in the procurement process, only 1/3 of the organization actually has sustainable procurement policies that apply to the purchasing of disinfectants. And more than half of them do not evaluate their implementation of these policies. Although on a positive note, 2/3 of respondents declared that they run market consultation before the tendering process. And as Anders said before, this can be a good opportunity also to discuss with supplier about your needs and make your claims demands for safer and more efficient products. We have also asked other factors that influence the procurement of disinfectants. And while the importance of product cost and its safety for the employees were not a surprise for us, I think it is important to note how the feedback from the staff using the product is key in the process, as it came third in the other factors that they consider. And this is something we have seen also throughout the case studies when trying to replace certain products. So having on board your healthcare staff is key in implementing sustainable procurement policies. And last but not least, we also asked participants to simulate a procurement of disinfectants and give award points to certain criteria. And what we can see in this slide is that when setting procurement criteria, product price and efficacy still prove to be amongst the most decisive factors for most of the users involved in the project. So with these results in mind, I'd like to stress that sustainable procurement is an area which makes use of their purchasing power to demand safer and more environmentally friendly products. And I would like to discuss a little bit more about that later on, but now I think we can directly dive into the case studies and give the floor to Manfred. Manfred has been already mentioned by Marion before. He's a PhD chemist and environmental engineer. He's part of the brain behind the VIDES database and supported the implementation of this project. He was responsible for the hazard analysis of disinfectants. And so he previously led also research in the ecological product policy at the Inter-University Research Center in Graz, Austria. And I will not delay further your presentation. Manfred, the floor is yours.
Yeah. Hello to everybody. I'm Manfred Klade. Since we are late, I will try to speed up a little bit in my presentation. I will first start a little bit about the theoretical background of the hazard analysis of disinfectants, because I think it's the crucial point is to understand what is the ABC categorization. This is the core step of the analysis. But basically, the hazard analysis of disinfectants supports or wants to support applicators and purchasers in the selection of less hazardous disinfectants without compromising hygiene requirements. And there are two steps. The first step is the indication of severe hazards arising from ingredients, which is called the ingredient analysis. And then in the second step, in case that there are severe hazards indicated, then less hazardous product alternatives may be searched and evaluated, which is the product benchmarking. And the second step, of course, is optional because it needs engagement of the client and both data. So I want to talk a bit or explain something about the first step, ingredient analysis. Well, 2 points. The first is the ingredient analysis uses the globally harmonized system of classification and labeling, GHS, as the main tool to indicate the hazards. And second point is it applies 3 categories to differentiate between the severity of hazards. And in this picture, you see the 3 categories, A, B, C. A color code is associated to each category. The red one, of course, is the most hazardous, and the B is something in between, and C is low. And the presumed concern is, of course, high, considerable, and low. We don't use the color green, which should be not to indicate something which is without hazard, because nearly every hazard ingredient is hazardous. In our case, in the case of disinfectants. Sorry. So what we associate to category R are hazards or hazard statements with which are proven irreversible, lasting, or have a high impact to human health and or on the aquatic environment already in very low concentration. And in the table on the right side, you see the hazard statement associated allocated to category A. Of course, the CMR hazards which are proven belong to them, and chronic toxicity H372, and the sensitizing hazards. And on the right column, you see hazards to the aquatic environment with their corresponding multiplication factors. Due to lack of time, I cannot go into details. I go further on to category B. Well, category B hazards comprise hazards with suspected irreversible or high impact to human health and or impact to the aquatic environment in low concentration. Additionally, this category also includes data gaps, which are indicated by the VIDES database. As you can see on the right picture, the corresponding hazard statements. I will go further on, otherwise it will take too much time to go through the whole thing. So now the category C is hazards which are either reversible or have a low impact, or are only effective only if improper handling or accident in case of poor working conditions or insufficient personal protective equipment. So we allocated all hazards which are concerning corrosiveness to or irritation to this category, to the low category. This is something maybe something confusing, because irritation is a common phenomenon in use of chemicals, but we think that it can be, on the other side, easily avoided by proper working conditions, for example. Now, what is the strength and the limitation of this hazard analysis? Well, the strength is, to my mind, it builds up on the globally harmonized GHS classification, which is widely used and will probably, hopefully, increase in the next years. It considers, in principle, it considers all ingredients, including fragrances, since it uses all the ingredient list given in the material safety data sheet, and it utilizes the most relevant classification. The analysis does not use the classification given in the safety data sheet, but it identifies the ingredient and then provide the VDES classification for this ingredient. And it also regards insufficient knowledge for hazard exclusion. This means the question marks which were indicated by Marian in the presentation before. Now, so the hazard analysis to a certain amount needs or uses the VDES database, and to the other side, the SDS from the applicators are also the other part of the data source. Now, what is the limitation? I want to mention a limitation which I think it's important to keep in mind. In our analysis, which we did for 40 hospitals in the first step analysis, we identified or indicated if the ingredients are category A or category B or C, and if they are category A, then we wrote into the document we state a substitution demand. If the disinfectant contain 2 or more ingredients category B, then we wrote a limited substitution demand. Of course, since these statements, the analysis, the first step analysis solely rely on the inherent ingredient hazards and not on the concentrations, this statement should not be overinterpreted, and it primarily displays that there should be a further analysis, respectively of product benchmarking. It is not. It's not an absolute statement for substitution. So this is good to keep in mind if somebody receives that. Now I want to go over to the second step of the product, which is the product benchmarking, and the meaning of the product benchmarking is to identify alternatives for products for which substitution demand is indicated. And this product benchmarking is, as I said, an optional step. Because it additionally affords knowledge about the ingredient concentration, which is normally in the, but not always receivable in the safety data sheets. It needs knowledge about comparable product alternatives with a comparable efficacy, and in principle it is it leads to a more or less intensive exchange between the evaluator and client, and it is time-consuming and affords a proactive client. Now, I'm not able, due to time lag, to go into a detailed description of the product benchmarking. I have to refer to my webpage and to a certain degree to the interim report, where you can find further information about the product benchmarking. I will now go into some details of the case studies we did with 5 hospitals. I start with the case study, and its focus is hand disinfection. It's a hospital in South Africa which shared 9 products with us, which were eligible for hazard analysis. The result was 0 products posed a severe concern, means there were no ingredients with category A, and 2 products used for hand hygiene contained chlorhexidine gluconate as the biocidal ingredient, which in our scheme is category B. So we recommended a limited demand for substitution in our first step analysis. And then we started our second product benchmarking, and there we concluded from the WHO recommendation and also from the content of the readers database that alcohol hand rub is preferred for hand hygiene. And so we concluded that chlorhexidine is not a necessary constituent for hand hygiene. And so as a result, the hospital was encouraged to substitute the 2 products with alcohol-containing disinfectants, and a list of potential alternatives was forwarded to the hospital. So in our scheme, it's now a substitution from B to C, which is also an improvement, an overall improvement. So here you can see the next case study. It's for surface disinfection. It's a hospital in Colombia which had 7 products with us, which were eligible for hazard analysis, and 1 disinfectant posed a severe concern and was recommended for substitution. The product is a high-level disinfectant for surfaces of medical equipment and devices, and contains glutaraldehyde and formaldehyde. And after an extended discussion and field trial, a product containing hydrogen peroxide was chosen as an alternative. So we could get an improvement from a category A product to a product alternative located in category C. So the next case study concerns laundry disinfection. It is a hospital in Germany which shared 21 products with us, which were eligible for hazard analysis. And there was a product for laundry disinfection which contained 3 allergenic fragrances, which are of category A, and peracetic acid, which is category B in our scheme as a main biocidal ingredient. And as an alternative, a product also based on peracetic acid but without allergenic fragrances was found. So it's an improvement from a category A product to a category B product in this case. Yeah, and then the most comprehensive product benchmarking concerns instrument disinfection. The starting point was a hospital in the United States which shared 8 products eligible for hazard analysis, and a substitution demand was constituted for 2 products for manual instrument disinfection of flexible endoscopes, due to the main active ingredient orthophthalealdehyde, which is category A due to the sensitizing properties. And despite that the hospital left, we decided to make a case study which was extended to a comparison of products covering all relevant active substances applied for manual instrument disinfection, in this case for flexible endoscopes, high-level disinfectants. We compared 5 products which contained 4 different biocidal active ingredients, 1 product with hydrogen peroxide, accelerated hydrogen peroxide, 1 product with peracetic acid, 1 product with glutaraldehyde, and 2 products with phthalalaldehyde. And here you can see which is a table which is normally given for the product benchmarking. I skipped this table. You can see the 5 products, and in the product benchmarking, hazardous loads are calculated. I cannot go into details about that. It is an expression of the cargoes which are emitted, of the hazardous cargoes which are emitted during use. And we have 4 categories. It's high aquatic hazard. It's an aquatic hazard which is a little bit lower in the multiplication factors, a sensitizing hazard, and a CMR hazard. And as you can see, the product which contains glutaraldehyde has the highest load, and the phthalalaldehyde are the next 2 products, and you have comparatively low hazardous loads of the peracetic acid product, and you have no hazardous load from the product containing the accelerated hydrogen peroxide. And since there is a controversy about the irritating potential and the asthma-causing activity of peracetic acid, which is well known and which was already mentioned in this webinar, we decided to add a literature review to this benchmarking result, and we collected empirical information about risk probably not depicted by the ordinary hazard classification. And of course, it is true, peracetic acid has a certain potential to cause irritating-based asthma, which is subclass of occupational asthma. But our overall conclusion was that it is the most recommendable is the hydrogen peroxide product, and the last recommendable is the glutaraldehyde product, and that probably from our point of view, at least the phthalalaldehyde product, the OPA product, they are more concerning than the peracetic product. But it is very important, and it was visible from the scientific literature that the lack of appropriate occupational safety measures play a big role in the occurrence of asthmatic symptoms or irritating symptoms. So this was my last slide, and yes, thank you very much for your attention. I hope you have now a bit insight in our work.
Thank you, Master. We have to go a bit quicker because we are running out of time, but I would like to remind you that all the information about these case studies and more will be available in the interim report into details. And now I'd like to give the floor to the Dr. and Professor Edda Weimann. She's the medical director of the Geisach Specialist Clinic for Chronic Diseases in Childhood and Adolescence in Germany. So she's professor of pediatric and pediatric endocrinology and holds a Master of Public Health from the University of Cape Town. Edda is the medical director of the hospital, but she lectures also climate change and health at the University of Munich and before at the University of Cape Town. Until now, she has transformed 2 hospitals, the University Hospital in Cape Town and her current one, to adapt and implement more sustainable practices. The various sustainability projects were published also in several papers. I will now give you the floor, Edda. Just wait 1 second that we show your presentation. There you go, you can start.
Yeah, thanks, Ariana, for the introduction, and thanks very much for having the possibility to share our results in a way from theory to practice. And I also would like to thank Sibylla and a big thank you to Ariana, who also participated in the study. So just to give you, because we don't have a lot of time, just the main headlines. So I'm working in a hospital with 220 beds, specialized in chronic diseases, and interestingly here for the study is that all our cleaning staff mainly is outsourced and works externally. We have 1 or 2 people who are working for us, but mainly it's outsourced and doesn't really belong to the hospital. What's also a different challenge. So when I took up my position at the hospital last year, I connected, in a way, reconnected back to the green and healthy hospitals, and we try to be green and healthy and have, for example, solar panels and try to reduce our environmental impact. So we did an analysis of the disinfectants last year and came out with 21 products that we analyzed with different categories that Manfred explained just before, and we also used this database for that. Just a sec, and also the analysis of the 21 disinfectants show that we choose disinfectants with a very high standard of occupational and environmental safety, although 5 disinfectants contained allergenic fragrances, and 1 product, the biocidal, was classified or is classified as chronic toxic and reprotoxic as an A category. So in a way, 6 products have been recommended for replacement and substitution. I just will briefly go through the products and also show the challenges and mention the challenges. So in a way, if we want to substitute a product, then the product must be listed by the National Institute, for us, the Koch Institute, or the FAC. Then, in a way, we also have to align to public procurement rules, and the alternative also should consider the interactions between the cleaning products used and the disinfectant product. In a way, it also must be easy and practical to apply, and the price of the alternative product should be comparable to the replaced one. So just highlighting the first one, the biocidal, that was the most sensible one that was really recommended for replacement because it's chronic toxic. So the Descocept wipes were tested as an alternative, but the nurses that had to use them didn't like them because they were not soaked well and also had higher costs, and in a way they just refused to use them. And the oxy wipes are a much better substitute. I've added it here, but they are a bit too pricey because they are 3 times higher price than the current one. Then going to the apicene, it also has 2 allergenic fragrances and also suspected of damaging fertility or unborn child. So it was replaced or is replaced with denard acid, but we still have to use it for the bathtub because after some special medical therapy, there is not really another alternative. Then the Kiel one also has allergic fragrances and allergic skin reactions, and it's not longer in use. So it has been replaced. Then the Electra 60 is also used for laundry, also categorized with a high concern, also suspecting damaging fertility and or unborn child. Used for laundry, so definitely has some impact of the aquatic environment. We replaced it. The alternative product is Lavabase Compact, and it has no sensitizing substances, so there is no additional destruction necessary, has even lower cost, but has a slightly higher impact on the aquatic environment. Acides Plus is also another one with a high concern, categorized with A, toxic if inhaled. That's also used by the external cleaning provider only for the swimming pool area, and it's very difficult to be replaced because there's multiple interactions with the swimming pool chemicals, and also the cleaner has a constant contract, and it's very difficult to interfere with this contract. I think a great alternative would be if we would have a saltwater pool, because then we would have to use less hazardous chemicals and chlorine, but unfortunately that's currently not possible. So sorry about that. And the last one, the Microbac Forte, also has 3 allergic fragrances, also categorized with A, used here in the hospital for floor cleaning. So, but the cleaning staff wear gloves all the time, and no allergic reaction has occurred until now. The replacement is also quite difficult, as the price for the replacement product is much higher. So what are the learning outcomes and next steps for us? So we are still investigating other alternative products. Oxygen-based alternatives are expensive, and sometimes the alternatives also associated with intense, in a way, bad smell. For us, national guidelines for sustainable procurement would be quite helpful, even to interact with our administration and to argue that we would need more sustainable and greener products. In a way, also when purchasing products, I think it also would be nice if the carbon footprint could be considered as well. For example, for the impact of transportation, if it's produced locally or overseas, I think that definitely has an impact. And also products should be labeled accordingly. It also would be nice for consumers to know what they're using, and for us as hospitals, for example, as an A, for example, if there is no hazardous substance and non-allergenic fragrances, and also produced locally. So that was in effect my last slide, and I like to thank everybody for listening and also everybody who has participated in the study. Thanks, Ariane.
Thank you very much, Eden. Thank you very much for participating in this project and for your time and effort. So as we said, we are running a little bit out of time, so I will just take a couple of questions, and then, as we said, the webinar is recorded, so the people that have to disconnect can disconnect, and we will share the recording with all the registrants. I take one question that is quite interesting, and this is for Anders, but also to other panelists if they want to comment. So many new disinfectant manufacturers have emerged during the COVID-19 crisis. How we should think about these untested preparations. For example, hand disinfectants, should avoid them and manufacture our own according to WHO recipe that is tested. I can repeat the question for you if it's not clear, Anders.
Well, I can just say during this pandemic, as I said, we had actually a severe lack of disinfectants. And the reason was mainly that people were hoarding disinfectants. Well, it could be a clinic that just, instead of ordering 50 bottles of hand sanitizer, they ordered 150. But on the other hand, we got offers from other companies with new disinfectants, and we made really clear that all these offers or suggestions from other suppliers should go through this project group with all these expertise. And we looked really carefully in the safety data sheet, and we asked questions if we had some doubts. And then we tried to sort of make a list. So the priority for the clinics out there and hospitals, they use or order the previously procured disinfectants that we actually have gone through the procurement process and we still have in stock. And we save these new disinfectants coming in for the real emergency situation where there is no properly procured disinfectants available. But I think you have to be, as I said, careful, look through the safety data sheet, ask for the ingredients, look at the product information, have a dialogue with a supplier offering these disinfectants. And I have to mention that there was one, or at least two, I guess, places where they had used the WHO recipe, and they noticed some occupational health problems with the hands. They had small wounds and blisters. I don't know if somebody else has some experience about the WHO recipes causing occupational health problems.
Okay, that's good to know. Interesting that we could discuss more about this in upcoming meetings. One last question about purchasing on the purchasing of medical devices. So Beth is asking, when purchasing medical devices, can you clarify if this was your recommendation that purchasers should take into account what disinfectants manufacturers recommend?
Can you hear me?
Yes.
Yes. Okay, good. I think you're going to have to repeat the question.
Yes, sorry. So it was, so when purchasing medical devices, you had among your recommendation to follow the
yes,
the manufacturers recommended, but I think that then you also had another recommendation about making sure when you purchase a product.
Yes. So all products that are procured within region Västra Götaland, I mean, not just the disinfectants have to go through procurement. All items that are bought, even medical devices and equipment, have to go through procurement. And the standard is that whatever you buy for the region, it has to be able to withstand the disinfectants that are already purchased within the region. So just that you don't end up with this problem, which we have done occasionally when people have bought a piece of equipment that has not gone through the right procedure, and then they say, you know, this has to be disinfected with this product, and we don't have it. So.
Okay, thank you. I guess this is answering the questions, and then I have a question for Marion from Madeleine. The dose of the disinfectants is of course crucial for the toxicity. but how to read medical safety data sheets that are based on the pure form of the substance. And then the question is, I have experience with suppliers who claim that personal protective equipment is not necessary if the chemical is diluted.
Yeah, I'm I don't think that I can answer this question without taking a look at these special safety data sheets. Usually, it's necessary to take some measures for occupational health. Maybe there are some exceptions, but without seeing the details, I'm sorry, I don't think that I can answer this question.
Okay, yeah, of course,
yeah.
It's important
to see the
product,
exact product and then the active substances and so on. Yeah.
I have another question for you from Shailant. After creating the database, how did the stakeholder respond? Are manufacturers okay with their data being shared to competitors, regulators, and other groups?
Yeah, interesting question. Yeah, when we wanted to publish the database, the companies sent us a letter that they will take us to court if we just publish the data. And we just work together with 7 lawyers just to be sure that we just fulfill all the needs for the safety of data and so on. And then we just published it. And we never got any other letter from companies after this. And when the companies realized that the database is used by many hospitals and also other institutions, they just checked that it's an advantage to be inside of the database. And so now we have a good cooperation with the companies, and a lot of companies just come from their side and asking us for integrating their products. And if we just find out that the product is, for instance, does not fulfill the criteria for pregnant employees, we just tell the company, and most of the companies just change the recipe, the composition of their products, and I think now it's quite a fruitful cooperation we got. So yeah, but it was a long way from I think more than 10 years. Yes,
but still it's encouraging.
Yes.
Yeah. Okay, thank you very much. So we still have many questions and unfortunately not much time. So again, we will feel free, we'll say to the participants, feel free to reach out to our speakers. And I would like to thank them again for their time and their presentation. I would just like to run very quickly through the next step. As I said, you will receive the recording of the webinar, the interim report with all the details about the project and the results and the methodology of the hazard analysis and product benchmarking presented by Manfred will be in the report. The workshop that we wanted to organize had 2 breakout sessions in the afternoon. One was supposed to be on sustainable procurement criteria, and the second was on the policy framework that would allow hospitals and public authorities to procure safer disinfectants and embed green public procurement criteria in their procurement policies. So what we will do after this workshop is that we will schedule 2 separate calls to discuss these 2 topics, and I would encourage the participants that are interested in attending one of these two courses or both, you are welcome, and you can let me know, and I will include you in this list. And the idea is that with the call on the sustainable procurement criteria, we can expand our expert working group working on disinfectants and produce harmonized procurement criteria that can be translated in different languages and be ready to use for procurers across Europe, but not only. And after we will receive, so that's for the next steps in terms of course and how to conclude the workshop and this work. But of course, the interim report that will be online is open to your feedback. So please send us your feedback and put your comments. And you have time until the 17th of May, and then everything will be compiled in a final publication and as a conclusion of this project. So I would like to thank again the speakers, but also the participants that stayed with us today. We reached almost 70 participants, and we had more than 120 registered. So that was a very good indication how this topic is important. And I would like to now the speakers can unmute themselves and thank you and say goodbye, but also like to thank our donors. So the webinar is concluded, and thank you very much again for your attention.